how the concept of molecular imaging came out. Molecular imaging started from a micro-imaging system for small animals. For example, we have micro-CT, micro-PET, micro-MRI. So we can get very nice imaging of entire body of the small animals, rat or mice. We can get the bioactivities. We even can see the small part, very detailed small part of the atherosclerosis of ascending aorta of a little mouse. And we have this kind of very nice software. We can find the 3D imaging. We also have optic imaging, which is becoming a new member of our medical imaging family. Optic imaging is very sensitive for detection of gene expression. We can use also high-frequency ultrasound to detect the tiny tumor at diameter of a couple of millimeters. So now this the molecular imaging system is now combined together to have this kind of hybrid system. For example, we may know that PET-CT, which provides anatomy and the bioactivities together. We have also PET-MRI. So not only for anatomy and bioactivity, also we have functional examinations. And also the scientists now trying to combine MRI with ultrasound imaging and put this ultrasound imaging system into the MR. So the purpose for this is that we have a dynamic blood flow with ultrasound, so we can combine this together to get this the dynamic imaging. And also now we try to combine MRI with optic imaging. And as I mentioned that optic imaging is very sensitive for detection of gene expression. So we can get this location of the gene expressed from the target. So now the molecular imaging at this stage, we have different molecular imaging techniques which become a very important imaging tool for basic science. Now the question is how to translate this advanced technique to humans. For example, for optic imaging, if we have the small animals, we have tumors and we use contrast agents to outline the tumor, we can easily use our optic imaging to detect the signal for small body of subject. But now, for the big animals or for human use, it is difficult. Suppose we have deeply seated deletions. We cannot send the light or detect light from the target because of the light scattering and reflection by the different layers of the tissues. So we have gap here. So what we can do is using our interventional procedures. We have interventional needle and send the percutaneous probe or imager close to the target. Then we can get this imaging. We also can use the naturally existing lumens of the body. For example, vessels or bioduct or ureters can send the kind of endo probe to detect this tumor. So then we can get this imaging. So our interventional radiology can help to solve the limitations of current molecular imaging techniques. This slide shows that the World Molecular Imaging Conference has different kind of sessions, not only focused on the early detection of cancer, so used in the different fields for basic science. Years ago, there is a new session come out called imaging-guided surgery and interventions. And in the year 2012, Harvard University and the US NIH has this kind of imaging-guided therapy workshop. The first time they organized this kind of a session called molecular imaging-guided therapies. And 2 years ago, I received a PhD thesis for evaluation from Netherlands. The title is Interventional Molecular Imaging. So this concept now has been recognized worldwide. So what is interventional molecular imaging? It is a new concept trying to fully combine the advantage of the two fields, interventional radiology and molecular imaging, to reach the deep-seated targets, to get a close look of small targets, to guide delivery of non-targeted tracers or therapeutics to enhance the targeted imaging and targeted treatment. The final goal is to facilitate the translation of molecular imaging to clinical practice. So what interventional radiology can do for molecular imaging? Let's see this. Use number 1 to reach deep-seated target. So we developed this kind of a percutaneous optical imaging technique. For example, here we started from vasculatures. For superficially located carotid arteries or femoral arteries, we can easily use this kind of surface optical imaging system to detect. So here's the design. So we have this kind of optical imaging probe like an ultrasound transducer. So we can send light to detect the carotid artery and get the imaging here. This is the first generation of surface optical imaging system. So here's we can send the light in, and then excite it the target and get this the bioactivity of light from the target, then imaging it. Here is one example. We transferred the saline to the right femoral artery and the GLP to the left femoral artery. So here's the result with our surface some autofluorescence from the artery itself. And this side, we can see that much more signal due to the GLP expression. And histology confirmed that we really have a GLP here. For deeply located the arteries, such as the iliac arteries, the abdominal aorta, or renal arteries, it's difficult to use the surface optical imaging to do this. I should mention that we have interventional procedures. We can send the needle and guide this percutaneous optical probe and to get the imaging. So here is the first generation of a percutaneous optical imaging system. So we have this kind of needle type optical imager at the tip. You can send the excitation light in and detect the signal from here. So this system placed in by the targets through the regular interventional needle. Here's the result, one example of result. Right side transferred with saline and left side transferred with GLP. We can get the same result. This signal, we can see the GLP expression. So now we can easily convert the system from vasculatures to cancer. Use number 2, getting a close look of small part. Basically, we want to see the luminal wall. This the tiny target. So why we do this is, so here is the conventional MRI. So this is the entire body, the coil here. So we take part of this coil to make this intraluminal coil. Why we do this? Let's see this example. So if we use conventional MR to examine the deeply seated, the atherosclerotic iliac artery, we can get a broad signal here. And here's the imaging result we got. This is cross-section view of the iliac artery. So you can see that at 3 o'clock here, there's signal change, but we are not sure what happened here. If we placed our intraluminal coil into the same artery segment, then we can get this kind of a very highly concentrated signal. So let's see what happened. This is exactly the vessel. Now we know that the signal change here is due to the formation of atherosclerotic plaques. So histology confirmed that we have a typical plaque type. This is a fiber optic cap and the lipid core. So I'm an interventional radiologist. I'm interested by the combine this technique with interventional therapies. So once we have this imaging, we can see the luminal wall. We can place the interventional devices, for example, the agent delivery balloon, to monitor the delivery the therapeutics into the target. So then we have this concept, intraluminal MRI guided interventions. We started from the vasculatures. Now we moved this technique to the biliary obstruction of the pancreatobiliary malignancies. As we know that this disease has a very poor prognosis, and it is unresectable when patient sees doctor, and it is not responsive to either chemotherapy or radiation therapy. So currently, the only palliative management is place the biliary stents. However, the problem is that once we place stent here to open the biliary duct, we can see that 2 months later, the tumor overgrows at the end of stent. and occlude the bile duct again. And also this tumor is very aggressive. It can infiltrate through the stents to the lumen, then it makes this occlusion here. So now we need to find alternatives to manage this problem. We started this project at Johns Hopkins University, and we developed this kind of intrabiliary MRI at the beginning. Then later we combined our interventional technique with this imaging technique. So here's the intrabiliary MRI in patients. We simply placed our intraluminal MR coil to the biliary draining catheter, the tube. Here's the PDC, the draining catheter. Then we placed our luminal coil into the catheter and connect to MR for imaging. So this is what we got. We got this coronal view of the abdominal, this MRI. So from here we can see that the coil goes from right bile duct to the common bile duct and duodenum. Once we get this route, we can precisely get this cross-section view imaging each portion. Then this is what we got. We can see that here's a normal bile duct is a bright and clean ring here. So we can see that entire the lens is very clear. And if we have tumor, you can see that here is a very earlier stage of cholangiocarcinoma. You can see how the tumor tissue infiltrates outside, like fingers go out. And here's another case, is recurrences of cholangiocarcinoma after surgery. So once we have this kind of the high resolution imaging, we can use our intervention procedures to treat it. This is a special agent delivery balloon catheter, so which has 3 channels. One is the balloon channel. We can inflate the balloon against the luminal wall. And from the guide wire channel, we can place our intraluminal MR coil to get imaging simultaneously. Through the third channel, we can deliver the agent, the genes or therapeutics into the balloon, and which connect to many micropores of the balloon. So once we use very high pressure to inject, we can push this, the therapeutics into the vessel wall. Here is the plan. What do we do? So we have the draining catheter, the PDCD draining catheter, place our special balloon catheter, then deliver the agent into the bile duct wall, and same time we can do the MR to monitor the delivery procedure. Here's the result. You can see that we delivered this mixture of the contrast agent with blue dye. So here is a cross-section view of the bile duct. You can see the bright signal due to this contrast agent. And so surgery, you can see the blue dye stent, the bile duct here. And microscope, you can see the blue dye, the infiltrate from epithelium to the medium. And this contrast agent emits the red fluorescence. You can see the entire bile duct wall occupied by the contrast agent. So in the control group ceiling, we didn't see this imaging. This is autofluorescence from the bile duct itself. And also MRI technology has many advantages. So for example, here we have 3D MRCP. So we can place the catheter in, deliver the agent. We also can use our intraluminal coil to deliver the external radio frequency energy to the target, to locally hit it, because we know that the hypothermia can enhance the chemotherapy or gene therapy. We also have MR thermal mapping, so we can instantly measure or record, monitor how the temperature distribute at target. So all this together, we can benefit the interventional treatment of biliary cancers. Use number 3 to guide the delivery non-targeted the therapeutics. Here we emphasize on the cell or gene therapies. For example, for brain, we have different routes to deliver the stem cell. We can locally injection. We can directly inject it to the ventricles, and we can use a catheter to deliver deliver the stem cell into the arteries, and also we can, of course, perform this intravenous infusion. Here's one example. So if we inject to create the rat glioma model by local injection. We have this kind of stereotactic system. So we can make this animal models with glioma. And then we can use the optic imaging contrast agent to outline this tumor. We also can use the same technique to inject stem cells into the brain. For example, before injection, we can use the MR contrast agent to label stem cells, then inject here. And 1 month later, we can use our advanced software to see how the stem cells migrate into the surrounding tissues here, like the crab legs here. Actually, this technique already been transferred to patients. So now we have this kind of very fancy system for brain injection of agent. So very simple. We have this. The yellow line is a pre-procedure planning line. This red line is the real injection line. So we combine it together. Then we just put needle in, then inject the stem cells or genes or do the biopsy. Also, we can use the same technique to monitor the laser ablation of the glioma. As I mentioned, that we have MR thermal mapping, so we can instantly monitor the temperature here. Use number 4 to enhance the targeted molecular imaging and treatments. I noted that there are several talks here regarding to the nanotechnology. So here, for example, there's nanoparticles. We can place our gene into the particle. We can place drug into the particle, and on surface there's targeting ligands to have a targeted delivery. And here we also can put the 2 drugs simultaneously. We have ligands for targeting, and then also we can attach the imaging visible agent onto the nanoparticle, so to get imaging. This concept is very clear that if we have targeted delivery, we can target this cancer cells only while protecting the healthy cells here. Now, let's compare interventional therapy with the targeted therapy. For interventional procedure, we use a catheter and put catheter close to the target, then deliver the therapeutics. For particle-based treatments, we use the systemic delivery approach, which circulates in the body, then through the venous system to the artery system, then go to the target to treat it. So for interventional procedure, we use the balloon. We use the catheter. It is catheter-directed, instant and minimal invasive approach. And this site, it is completely dependent on the receptor of tumors. So it is non-invasive and it's targeted. But problem is that it is non-instant because the particles need to circulate in the entire body. It can be cleaned through the kidney or trapped in liver or released from the lungs. So now we are thinking about to avoid this cleaning problem by placing our catheter close to the target. Then we should have this kind of super targeted treatment. For this purpose, we need is the nanoparticles to be imaging visible. So now we have it's optic imaging visible or MRI or CT visible nanoparticles. So we can convert these particles to be a therapeutic carrier. Then we should to apply to the system. Then we can have this interventional molecular imaging. We have more work to do. So about talking about interventional in assisting the molecular imaging, we can also use molecular imaging to evaluate the interventional procedures. So here's one example. I should mention that hypothermia can enhance the therapy, gene therapy or chemotherapy. So here's why it works. So once we deliver this chemo drug into the target, the drugs cannot easily get into the cancer cells. If we apply the RF heat as 42C, then we can get the integrity of the cell membrane temperature loss or any channels open, so which facilitate the chemo drug into the cells to kill the cells. So now we want to adopt this concept for our interventional molecular imaging technique. This is one example. We have a new mouse. We implanted the tumor here. Then we directly inject the drug here, and at the same time we heat this area for 42C. Then we use a different molecular imaging technique to evaluate the therapeutic result. Then we have a pathology for correlation. Here's one example of optical imaging of radiofrequency heat enhanced chemotherapy of esophageal cancers. Here we have different groups. We have control, the RF heat only, the chemotherapy only group, and here is the combination therapy with radiofrequency enhanced chemotherapy. We can see at even day 14 of the treatment, both signals and size become smaller in this group, which is confirmed by the pathology. Of course, in this case we use allogenic model. Now we use to confirm this concept with orthotopic models. Then we creation these models. So here is the one protocol. We use luciferase to label the esophageal cancer cells. At the same time, we build this kind of manufacture this micro intervention devices. Then under ultrasound guided through the orally we place the system in and inject the cells, these labeled cells into the esophageal wall. Then we can use the optical imaging to detect the signal here. Then histology confirm that we have infiltration here, the entire tumor here. So once we have this the orthotopic model, we can validate our concept of interventional molecular imaging. So here again is the optical imaging of the chemotherapy treat the esophageal cancers. You can see that the same thing. We have 4 groups, and in this group, the combination therapy is the both signal and size decrease here. And also we can use ultrasound imaging to quantify the volume of the tumor. Here's histology. We have more apoptosis in this group. So here's the one example. Here's another example of molecular MRI of chemotherapy of the pancreatic cancer. So we started using the allogenic model. So here again, we have 4 groups here. You can see that in the combination therapy group, at day 14 of the treatment, the tumor almost disappeared here. So that means it works. Of course, we need orthotopic model. We do this again using luciferase to label the pancreatic cells, and then we implant the cells into the donor rat, the legs of donor rat, to get this tumor. Then we harvest the tumor and chop into the pieces, then through the laparotomy to insert this tumor pieces into the pancreatic head of the recipient rat. Then 2 weeks later, you can see that we already see this manifestations of jaundice. Here we can see that the yellow eye and yellow skin. Then we can use optical imaging to detect the signal from pancreatic head due to this the growth of the luciferase labeled pancreatic tumor. Of course, then we can also use molecular MRI. We can get exactly the same imaging contrast MR like in humans. You can see the tumor at the pancreatic head. Here's histology. You can see the tumor compress the duodenum. We have histology confirmation. So once we have this model, we can validate our interventional procedures. We can evaluate the new drugs, new genes, and so on. So what is the direction of molecular imaging? So now, in bench science, in basic science, there are many molecular imaging techniques. The PhDs have done an excellent job for this work. But problem is that in clinical part side, there is very little application. This is because that the basic scientists do not have direct access to patient care, and the clinicians are very busy for clinical practice. They don't know what happened in basic science. So there's a gap here. Now we need a bridge to connect these 2 fields. That's why the NIH mentioned that raise the question, this is the translational medicine. We need to develop the molecular imaging instrument for human use. We need to validate those imaging techniques in near human-sized animals prior to FDA approval. Here's one example. For example, 12 years ago, one optical engineer built this prototype of optical system. So now it becomes a reality. Now we can place patient here and place the breast inside of this hole. We can get optical tomography. So now it's used in human already. And also this optical imaging now transferred to operating room. So during operations, we can see clearly the tumors here. We also can examine how the tumor spread through the lymphatics. You can see that this is the spread rot here. So then we can enlarge the cutting area or remove more tissues. So to facilitate the clinical translation of molecular imaging, Harvard University Brigham and Women's Hospital has built this kind of suite. So there's 3 rooms. In the center, there's interventional radiology room or operating room. Then patient can be transferred to this another room for PET-CT, for molecular imaging. And also, in this end, we have functional imaging. So this slide tells us that now the infrastructure of a modern hospital starts to be changed to do the more work to combine the different specialties together for personalized medicine or precision medicine. In conclusion, the interventional molecular imaging is a new concept which fully combines the advantage of 2 fields. We can use interventional procedure to assess molecular imaging, and also we can use molecular imaging to evaluate the interventional procedures. The final goal is to facilitate the clinical translation of molecular imaging to clinical practice. I want to acknowledge this entire team members, our team through the years. Of course, this different project is supported by different funding agencies. Thank you for your attention.